All right. Hi, everyone. Welcome to Pediatric Grand Rounds. I am going to turn over the session today to Dr. Mel Hyman to introduce our speaker.
Thanks, Rafi. It's my pleasure to introduce a good friend of mine, Francisco Silvestre, Dr. Francisco Silvestre. Originally, he's from Lima, Peru, and spent some graduate years working at the Nutrition Research Institute in Lima. Then eventually got into a pediatric residency program at SUNY Downstate in Brooklyn. He was a chief resident there and then subsequently did his pediatric gastroenterology training at the Hospital for Sick Children in Toronto. He started his first faculty appointment at Connecticut Children's Medical Center in Hartford, Connecticut in 1996 and was there until 2014 when he was recruited to his current position as Division Chief of Pediatric Gastroenterology at UNC in Chapel Hill, University of North Carolina. He is a professor there. He also is the director of the Pediatric Gastroenterology Fellowship Program. And he also has very strong interests in pediatric inflammatory bowel disease and skeletal health in children with IBD. And he has been fascinated by the role of vitamin D as a hormone, influencing the expression and function of many genes. And you'll see from today's title, he's enticing us to listen by his title of Vitamin D, D-light or Debunked. So Dr. Silvestre, please.
Thank you, Dr. Hyman. Thank you, Dr. Hirsch, and also Dr. Van Schaik for reviewing the presentation before today. Can everyone see my slides okay? And can you hear me okay?
Yes, to both.
Okay, thank you. So this is my only disclosure, which is not relevant to today's talk. My goals today are twofold. Number one, become familiar with the role of vitamin D and calcium in nutritional rickets. Other forms of rickets will be alluded to, but not addressed specifically. And understand the effects of vitamin D on the immune system and on specific medical conditions. So first, a little bit about nomenclature, which can be a bit confusing sometimes. Generally speaking, there's two forms of vitamin D that are relevant to human health. The first one on your left is cholecalciferol or vitamin D3. And the second on your right is ergocalciferol or vitamin D2. I highlight the methyl group substitution and the double bond that differentiates the two molecules. Vitamin D3 is synthesized by animals, including humans, and commercially available vitamin D3 is extracted from sheep wool. They actually extract lanolin. Lanolin is converted to dehydrocholesterol and irradiated, much like in human skin, to come up with vitamin D. And commercially available ergocalciferol is derived from yeast. Now, vitamin D3 and D2 should not be confused with 25-OHD or calcidiol and 125-OH2D or calcitriol. Both of these, in fact, can be either D2 or D3. A little bit about units. 25-OHD is the preferred metabolite to measure in blood to assess for vitamin D stores. And it is expressed either in nanograms per deciliter or in nanomoles per liter, and the conversion factor is shown. Lastly, with the advent of clarity in medical records, the nomenclature of international units is being withdrawn in favor of expressing the dose of vitamin D in micrograms. 40 international units of vitamin D equal to 1 microgram. When you get a report of a quote unquote vitamin D level, you get a report of a 25 OHD level, which can be either D2 or D3. With the open medical record, patients sometimes contact us saying, "Doctor, my vitamin D2 level is 0." And I say to myself, well, congratulations, you're not yeast. You're a mammal, and therefore you make vitamin D3. And unless you take a supplement, you should not have vitamin D2 in your system. So let's present our first case. This is a 50-month-old Hispanic girl with biliary atresia with partial drainage after portoenterostomy or Kasai operation, who is admitted for fever due to presumed cholangitis. On admission, she is clingy and irritable. She refuses to stand and has whitened wrists. She is on a regular diet plus nasogastric progestamine, which provides 604 calories per day or 300 international units of cholecalciferol and about 500 milligrams of calcium. In addition, she's on Aquadex, which is a water-soluble form of fat-soluble vitamins that provides 600 units of cholecalciferol. So you can see that she has a very robust supplement of both vitamin D and calcium. However, in her blood work, you will appreciate a few things. Number one, her calcium is actually normal. However, her alkaline phosphatase is quite elevated, even accounting for normal growth in a child this age. Her phosphate level is low, and her vitamin D total is low as well. In addition to that, she had a skeletal survey that identified multiple fractures, including fractures in her forearm that are signaled by the arrows. And the lower arrow over here shows the fraying of the epiphyses and lack of mineralization of ossification centers in the wrist of this patient. So she had good reasons why she was irritable and clingy and refusing to stand. She had fractures. She actually had a femur fracture as well. So this is an example of a patient with nutritional rickets. And I'm going to briefly review other features of nutritional rickets that you may see in your patients. So large anterior fontanelle is possible. And in fact, this patient had a large anterior fontanelle that was not closed yet, as well as frontal bossing. The key findings in young children on X-ray are on the wrist. So here are some typical findings shown by the arrow on panel A. You can see the cupping and fraying of the metaphyses of the radius and ulna. On the right on panel B is same patient's X-ray of the knee showing similar findings. And on the right is an X-ray of the patient after treatment with vitamin D for about 10 months. And you can see right away the differences between the surface of the bone on both the X-rays, as well as the amount of mineral that is laid onto the bone and the robustness of the calcification centers. These are other symptoms of nutritional rickets, some of which I have seen, especially during my training at Downstate in Brooklyn, where we had a large African-American population. Hypocalcemic seizures and tetanic spasms, hypocalcemic cardiomyopathy, bone pain and muscle weakness, as in this child, limb deformities, failure to thrive, developmental delay, and in persistent rickets that is untreated, it can actually affect the birth canal. So why does this all happen? So it's important to understand some basics about vitamin D metabolism. So we make 7-dehydrocholesterol in the skin. This is a precursor of vitamin D, and it is basically in our skin. Upon radiation with UVB light, this is converted to cholecalciferol, and cholecalciferol circulates and becomes hydroxylated in the 25 position in the liver. Then this 25 OH cholecalciferol circulates bound to vitamin D binding protein. Some of it is free, goes to the kidney where it's hydroxylated in the 1 position to become 1,25-dehydroxycholecalciferol. This is the active form of vitamin D and is highly regulated minute by minute. And this is why we don't measure it routinely as an indicator of vitamin D stores. In fact, in nutritional rickets, this can be normal or even high. The effect of 1,25-dehydroxycholecalciferol is primarily in the gut and also in the kidney. In the gut, it promotes increased calcium absorption, which is going to go back into the bone. And in the kidney, it promotes calcium absorption as well and goes into the bone. Now, cholecalciferol can be also ingested in the diet, and some aspects of our diet are richer than others in vitamin D. We're going to go into that in a few seconds. So UVB light is the right wavelength to synthesize vitamin D in the skin. The optimal conditions for vitamin D, environmentally concerned, is sun at 45 or 45 degrees over the horizon, typically between 10 a.m. and 3 p.m. UV index more than 3, and then spring and summer, particularly in temperate regions. So, however, there's concerns about the emergence of cancer in people that are exposed to sunlight. And therefore, there's really no safe threshold of UVB exposure that allows for sufficient vitamin D synthesis without increasing cancer risk. So we have to think about supplementing. So who is at risk for vitamin D deficiency? So number 1, individuals with dark skin, because melanin absorbs UVB and will impair the synthesis of 7-dihydrocholesterol and cholecalciferol. Wearing sunscreen appropriately, and then individuals on northern or southern latitudes are at risk. As far as intake of vitamin D is concerned, decreased intake of foods that contain vitamin D, malabsorptive syndromes such as celiac disease, cholestatic liver disease, pancreatic insufficiency, and other mucosal diseases. And on the other hand, obesity, mostly because of diet selection as well as deposition of vitamin D in the fat. Liver disease, chronic liver disease, particularly end-stage liver disease, is a risk factor for developing vitamin D deficiency when the ability to hydroxylate in the 25 position is impaired. This happens really late in liver disease. Or chronic end-stage kidney disease, where the ability to hydroxylase in the 1 position is impaired. So when you think of your patients who come into your attention, not everyone needs a vitamin D level, but you should think about getting a vitamin D level in individuals who may be at risk. What are the consequences of vitamin D deficiency? So vitamin D deficiency will result in a decreased concentration of 25-hydroxycholecalciferol. This in turn will result in a decrease in calcium absorption in the gut. The decreased calcium absorption causes hypocalcemia, and calcium is critical for a number of cellular functions and is maintained in a very narrow range. Therefore, the calcium sensing receptor is activated and PTH is released. This causes bone resorption, and bone resorption results in turn in freeing calcium from the bone matrix. On the kidney side, there is activation of synthesis of active vitamin D, and also increased reabsorption of calcium in the distal tubules, and impairment of phosphate absorption in the kidney, resulting in phosphaturia. So calcium is preserved at the expense of phosphate. And going back to the case, you can see in this child the consequences of this vitamin D deficiency. So number one, calcium is preserved. Number two, phosphate is lower. And number three, there is increased bone metabolic activity due to bone resorption. And this weakens the bone because it becomes demineralized and therefore softer and easier to fracture. So what do we need to make strong bones? So we need basically three things. We need calcium, we need phosphate, and we need a bone matrix. If any of these three elements are insufficient or altered, there can be consequences on bone strength and bone structure. In the case of rickets, rickets can be either due to conditions that lower calcium or conditions that lower phosphate. So we will not discuss these conditions today. And the most prevalent condition that lowers calcium is nutritional rickets. So far we have reviewed vitamin D metabolism and individuals who might be at risk. So let's review a little bit about the recommended levels of vitamin D in healthy people. And I underscore healthy. So there are multiple societies that have weighed in. You can see here the societies that are in America. So the Institute of Medicine or National Academy of Science, American Academy of Pediatrics, and the Endocrine Society. Everyone agrees, every one of these three societies and others agree that a 25 OHD level that is under 12 nanograms per milliliter is a setup for developing nutritional rickets. There is no debate about that. Where the debate is, however, is what is sufficiency, insufficiency, and toxicity. And as you can appreciate, there's absolutely no agreement. So in the green is what will be considered sufficient. And so you can appreciate right away that there's discrepancies in opinion. To highlight this, I present you with the two kind of sluggers in this debate. One is the Institute of Medicine, and the other one is the Endocrine Society. And just quickly perusing the definitions of deficient, insufficient, sufficient, and no added benefit and possible harm, they're really discrepant. So why is this? Why are reasonable people disagreeing? So the thought is that the way we measure vitamin D is has to be standardized and standardized better. So immunoassays for vitamin D are not terribly reliable, and the gold standard is becoming liquid chromatography with tandem mass spectrometry. There is a federal initiative to try to standardize methods to measure vitamin D in order to reduce the bias of these tests, and this is led by the CDC. This is an important program called the Vitamin D Standardization and Certification Program. They have been active for the past 8 years to 10 years. And in that period, they have reduced the systemic bias of these measurements by a tremendous amount. So this is a voluntary program, not mandated, but it is worth asking your institution whether they are participating. So I want to underscore that vitamin D, when it comes to rickets, is not the whole story, and that calcium is at least equally as important. I will present you 3 studies and then give you references for some more to underscore this point. So this is a study in young children with rickets. The interesting finding was here that these patients with rickets had lower calcium intake than the controls, but similar exposure in key. They had basically the same 25 hydroxy vitamin D. And interestingly, 67% of these children with rickets had 25 OHD above the rachitic range, what is considered at risk. So these patients had basically normal vitamin D levels, but they still developed rickets due to lower calcium intake. Another study shows similar findings. So in this study, the mean intake of calcium was significantly lower in cases of rickets versus controls, but there was no significant difference in serum 25 OHD level, which were both in the deficient range, or sun exposure among cases and controls. Finally, another example, this is a more recent study where serum 25 OHD levels were measured in patients in a study to prevent nutritional rickets in Nigerian children on a low calcium diet. And these findings are consistent with the above. These are the odds of nutritional rickets on the vertical axis and the serum 25 OHD level in nanomoles per liter in the horizontal axis. And you can see that for a given intake, for a given level of vitamin D, the intake of calcium, 130 to 103 milligrams per day, affected the risk of developing rickets significantly. And this was true across all serum 25 OHD levels. In fact, even having a level of 60 nanomoles per liter, you divide this in your brain by 2.5 to have the kind of the usual units that we have. So let's say 30 something, you still had a odds of developing rickets that were twice as much as in controls. So these are really pivotal studies. These are other examples of similar studies. So essentially, the risk of rickets increases, obviously, as the vitamin D level goes down, but also when the intake of calcium goes down. And even for levels of vitamin D that are quite low, if you take in sufficient calcium, the person is unlikely to develop rickets. And why is this? Because at the end of the day, what vitamin D does for us is that puts calcium in the body. So if you're getting calcium in your body, you will not develop rickets. In fact, you can treat rickets without vitamin D if you give calcium IV, circumventing the need for absorption. So the critical nutrient here is calcium, and vitamin D, what it's doing is facilitating its transport across the intestinal barrier. So both are really, really important. This is another reason why societies probably cannot agree, because calcium intake really has not been addressed as a modifier in the risk of clinical rickets in the American population. So these are data in healthy children. So this is from the NHANES survey to 2017-2018. Here is vitamin D, calcium, and phosphate. And even though phosphate is, of course, very important for bone mineralization, is usually quite abundant in the diet, and we don't worry too much about the intake of phosphate. We worry more about the intake of calcium and vitamin D. Again, 1 microgram is 40 international units of vitamin D. So you can see that as a whole in America, from the ages of 2 to 19, we're not doing too bad in terms of intake of vitamin D and intake of calcium. So this is about 200 units of vitamin D across the board. However, when you break it down a little further, we see that there are populations that are at risk for vitamin D deficiency. and that includes non-Hispanic, Blacks, or African Americans. So their intake of vitamin D in general is lower, and more equally important, their intake of calcium is also lower. And this puts these individuals at risk for developing rickets, something that I certainly saw during my residency. So to prevent nutritional rickets in healthy children, and let me underscore healthy children, these are the current guidelines. So from birth to 12 months is 400 units daily, or 10 micrograms. For kids over 12 months is 600 units. And in pregnant persons, it is the same 600 units. And we do a lot better by, with our vitamin D intake, because a lot of our food is fortified, particularly cereals, dairy products, and others. So compared to natural consumption of food sources like salmon, other oily fish, irradiated mushrooms, etc., our consumption of foods fortified with vitamin D is greater, and therefore it provides most of the vitamin D from food. So here is some examples of food sources of vitamin D. Fortified milk, orange juice, infant formulas, of course, etc. But a note of caution here: depending on the brand, you're going to get different amount of vitamin D, and that is worth checking if you're prescribing or recommending specific brands to your patients. These are all fortified with vitamin D or are naturally occurring, like in egg yolk. Same happens with fish. These are all vitamin D3 or cod liver oil, vitamin D3. Sources of vitamin D2 for vegetarians are shiitake mushrooms, particularly if they are sun-dried or irradiated. They have a lot of vitamin D, vitamin D2. Or Drisdol, that has also a very high concentration of vitamin D2. Drisdol is a commercially available vitamin D supplement. These are other possibilities to increase intake of vitamin D2 and D3. So there's a number of preparations out there in the market. Vitamin D3 preparations are becoming much more prevalent, and most of them are available over the counter, including very high doses like 50,000 units. Now, to treat rickets, you have to give more than 400 to 600 units daily. And the recommended dose is 2,000 units or 50 micrograms of D2 or D3. For this purpose, they're thought to be equally effective. Daily orally, and importantly, calcium. And this should be done at least for 2 weeks, if not longer, depending on alkaline phosphatase, phosphate, and clinical manifestations of nutritional rickets. In addition to this long form of treatment, there's also experience with what's called STOS therapy. STOS basically is like a punch of vitamin D. And I learned this technique from my mentors at Downstate, and you may remember Dr. Larry Finberg, who spent the last years of his career at UCSF. So in this paradigm, we used to give 600,000 units in a single day, divided in 6 doses, each of 100,000 units. And this was all in one day. And 1,000 milligrams of calcium daily. And after 3 months of doing the 1,000 milligrams of calcium daily, this is for 3 months. You would give additional 3 months of 400 units daily. So with this regimen, patients who typically would not return back to the clinic would at least be treated with a high dose of vitamin D, which would improve their scores. So we're underscoring the importance of calcium as well. And these are some calcium salts that are available for supplementation. The cheaper one is calcium carbonate and has the most calcium per gram compared to citrate, lactate, or gluconate. However, its absorption is pH dependent, and it is insoluble in alkaline pH. However, in the gastric acidic pH, it becomes quite soluble and can be absorbed. The same is true to some degree for calcium citrate, but not the others. For vegetarians, these are some plant-based foods that contain absorbable calcium. Bok choy, Chinese cabbage, broccoli, which I'm sure you can taste in the delicious Chinese food that is available in San Francisco, kale, and other products, including soy-based products and calcium-fortified orange juice. These can be given to individuals who are vegan or vegetarian. So back to the case. So this patient was treated with 10,000 units daily of vitamin D3 plus 500 milligrams of calcium daily for 6 weeks. And she really was a remarkable turnaround. It was great to see for our residents because she was literally pain-free within a day or two. Her fractures healed. And going back to her labs now, you see now that the alkaline phosphatase has decreased to about half. Her PTH normalized, her calcium remained normal, and her phosphate is now normal. So this is basically what you want to see. But this is really cool. And again, I had the chance to see this during my residence day. It was just amazing how that happened. So for the first part of this talk, these are the take-home messages. The main one is that the risk of nutritional rickets depends on both vitamin D and calcium intake, both. Current thresholds for vitamin D deficiency are determined for populations that consume sufficient calcium, like our population in general. However, they're not applicable in populations with low calcium intake, where with a given vitamin D level that appears okay, you still may develop nutritional rickets. So we're going to go now to a second case. This is a 14-year-old girl treated for Crohn's disease with infliximab, which is an anti-TNF blocker, who was doing well, but now presents with symptoms of active disease. Because she gets infliximab, she also gets blood work routinely, and her last infusion was 4 weeks prior. At that time, her serum 25 OHD level was 22 nanograms per milliliter, which is considered okay. And calcium phosphate and alkaline phosphatase were all normal. Her parents state that they have read that vitamin D is good for Crohn's disease and request that you boost her level to over 50 nanograms per milliliter to treat her flare based on the research. What would you do, and where are the parents coming from? So the story dates back to the pre-antibiotic era of treatment of tuberculosis. At that time, there were a number of sanatoria spread throughout the world where patients were exposed to direct sunlight to treat their TB, typically in areas of higher altitude. In the United States, for example, Denver. And these kids, for example, had surgery for Pott's disease, which is spinal tuberculosis. Others didn't. And they were exposed to direct sunlight. They seemed to be happy, at least smiling from the photograph. And this is in the UK. Now, the Bay Area was not an exception to these sanatoria. And in fact, you have one in San Francisco, in San Mateo, which was called the Hessler Health Farm or the San Francisco Health Farm. Now, this has been demolished. It is a public park. So in looking at this, though, I think maybe the weather during the time of this photograph was a little cool because these people are not getting much sunlight, even though they're outside. So some of this was predicated on the work of Niels Feinson, who received the Nobel Prize in Physiology or Medicine in 1903 because he recognized that cutaneous tuberculosis, also called lupus vulgaris, was responsive to concentrated light radiation. And the prize was given to him because he had opened this new avenue for medical science. So solar radiation, basically curing cutaneous tuberculosis. So many years later, we really have to fast forward to the mid-2000s now. The mechanisms behind these antimicrobial effects started to become elucidated. So I'll walk you through them. This is a cartoon where you have bacteria, and bacteria are being recognized by certain receptors in the membrane called toll-like receptors. This recognition leads to upregulation of the enzyme that hydroxylates vitamin D from the 25 position to the 125 position. And after this hydroxylation, vitamin D translocates into the nucleus where it binds to its nuclear receptor, the vitamin D receptor, and a co-receptor called RXR. And this leads to a number of events, including endocytosis of bacteria and destruction, so increased bacterial killing, increased synthesis of natural antibiotics such as cathelicidin and human defensin B, increase in other pattern recognition receptors other than toll-like receptors, some of them important in Crohn's disease like NOD2, increase in certain cytokines and chemokines, and also a decrease in some pro-inflammatory cytokines. So a number of immune effects from vitamin D. And this not only pertains to bacteria, and by that I include also mycobacteria, but also viruses. So viruses similarly recognized by toll-like receptors, upregulating the 125 hydroxylation of vitamin D, binding to its nuclear receptor, and destruction of the virus through phagocytosis, a number of immune modulatory effects on cytokines and other factors, as well as increased synthesis of this molecule with targeting of the endosome of viral double-stranded DNA and destruction. So pretty cool, right? Now, what's interesting about these effects is that unlike the effects on calcium homeostasis, they are completely independent of parathyroid hormone. PTH here plays no role. The important regulator here is the availability of 25D. So if this person has sufficient 25D, in theory, you're boosting your ability to fight infection, you're boosting your innate immune system, and you're also decreasing the activity or your adaptive immune system. So in Crohn's disease, where it is thought that the innate immune system is not working too well, and the adaptive immune system is overactive, given vitamin D as treatment appears to make total sense. So these effects have been well documented in the literature by multiple authors. So this is an example of decreased activation of the adaptive immune system, so activated T cells, through the vitamin D receptor. These are experiments in mice. And this is a paper, a seminal paper, that described the how toll-like receptors triggered vitamin D-mediated human antimicrobial responses by increasing the synthesis of cathelicidin. And this paper appeared to be really providing mechanistic underpinnings for the effects of solar radiation on cutaneous tuberculosis and other forms of tuberculosis, because vitamin D theoretically would help you kill mycobacteria. Specifically in IBD, is studied a lot in models, experimental models of IBD. One of them is the IL-10 knockout mouse. And in the IL-10 knockout mouse, vitamin D deficiency exacerbates experimental colitis and increases mortality. And supplementing vitamin D decreases colitis activity and decreases mortality. Moreover, if these mice cannot respond to vitamin D because they are deficient in its receptor, they develop more severe colitis and have higher mortality than in those with intact vitamin D receptor. And indeed, these vitamin D receptor knockout mice appear to have a genetic predisposition to developing IBD because their electrical resistance is significantly reduced even before the clinical colitis symptoms ensue. So these data, very provocative, would suggest that vitamin D has a pivotal role in regulating intestinal inflammation, at least in mice. There's also epidemiological data showing that higher predictive vitamin D status is associated with reduced risk of Crohn's disease, and that high residential sun exposure is associated with a low risk of incident Crohn's disease in a prospective cohort in Europe. So strong epidemiological data showing the benefit of vitamin D or sun exposure. And then another paper showing that normalizing plasma 25-OHD is associated with reduced risk of surgery in Crohn's disease, right? So, and the data show exactly that. However, what's really the story here? Is vitamin D panacea or snake oil? So the key thing here is to understand the following. So far, what we really have is really great experimental data that vitamin D may be beneficial to control intestinal inflammation, and optimizing vitamin D may have clinical benefit. But so far, we have correlations and associations. We yet do not have causation. And the reason why relying on purely on epidemiological data can be risky is that the relationship between the exposure and the outcome is modeled by confounders. So for example, people who spend more time outdoors may develop higher vitamin D levels, and their healthy lifestyle is really what impacts IBD and not the vitamin D itself. Vitamin D would seem to be a marker of sunlight exposure. Or people who have higher levels of vitamin D, it turns out that they're eating more oily fish, and something in the fish may be the one that is causing the benefit. So what we really need is double-blind, placebo-controlled clinical trials. So what is the story with those? So some good news, delight, right? And if you want to really know more detail, this is a wonderful summary in the Journal of Bone and Mineral Research published earlier this year on all clinical trials with high-dose vitamin D and adjusting for vitamin D deficient or sufficient state. Really a great summary. So we know that supplementation of vitamin D can help the bone mineral density of spine and hips, particularly in older people, arterial function, lung function, and possibly beneficial against cancer mortality. However, there is some disappointing news too. And that is that vitamin D supplementation does not prevent cardiovascular disease, cancer, fractures or falls, or tuberculosis, even though the in vitro data were promising. So going back to our case, we have this 14-year-old girl treated with infliximab previously well, comes in sick, no evidence of nutritional rickets, with the baseline lab values that are normal. So should we supplement oral vitamin D to increase her 25-OHD level above 50 nanograms per milliliter as requested by her parents to treat her disease? So there are some preliminary data that it might be helpful. So this is a study by Dr. Cantorna, who has done a lot of work in this area. On the vertical axis is the Crohn's disease activity scores, which is an indicator of disease severity. And you can see that in this trial, supplementing with vitamin D decreased the mean Crohn's disease activity index score significantly. And this is a quality of life score, where supplementing with vitamin D increased the score, the mean score significantly. But you can right away also appreciate that there's a great amount of overlap, and also that the number of subjects was relatively small. This is another study of vitamin D versus placebo against small numbers. So 48 analyzed on the placebo arm and 46 on the vitamin D arm. And these patients were supplemented for a year with 1,200 units of D3 plus calcium, or placebo plus calcium again for a year. And notice again that the dose of calcium was pretty high, and this could have muddled the benefits of vitamin D. But nonetheless, if you look at this Kaplan-Meier survival curve, supplementation of vitamin D was numerically superior to placebo in terms of the primary outcome, which was to see if there was an increase in disease activity in these two groups. So that was less likely in the vitamin D group numerically, but it did not reach statistical significance. More recently, this was just published this year. This is a study on high dose vitamin D, and the outcome here was recurrence of Crohn's disease after surgery. And these patients received 25,000 units of vitamin D3 weekly or placebo, no calcium, over the course of the study. The baseline vitamin D level was fine in both groups. And indeed, supplementing with 25,000 units weekly increased the vitamin D level in those who received the supplement by 40 nanomoles per liter after 6 weeks. And in the placebo, there was a non-significant increase. However, the rates of recurrence in the groups were the same. So a little bit of mixed signals. So, and that's the best we have to date. So vitamin D supplementation is associated with favorable outcomes in specific conditions. So not a panacea, but perhaps selective for some conditions where there's proven benefit. There is strong epidemiological, clinical, and laboratory evidence that vitamin D may help patients with IBD, but we need trials to really understand the role of vitamin D in our therapeutic arsenal. So would you supplement your patients? So with that, thank you very much for your attention. I'll stop sharing my screen, and I hope to get some questions.
You've got a lot of questions. Thanks, Francis. That was really a wonderful talk, and there's obviously interest because the questions have come in. So I'll start with some of the ones that have come up. First one was, how important is vitamin D supplementation in mild chronic kidney disease, especially given the hydroxylation at the 1 position?
Yeah, so I'm not a nephrologist, and that might be a better question for a nephrologist. But so I'm not exactly sure what mild chronic kidney disease means. But the thing that is at risk here is calcitriol, right? Not so much 25-OHD. So if there's something to supplement, it will be calcitriol with monitoring. Because with calcitriol is bioactive, you have higher chances of toxicity, such as hypercalcemia, that can produce nephrocalcinosis and worsen your kidney disease. So I would pay close attention to monitoring in addition to supplementation.
There's a follow-up question about the differences in absorbability of different calcium salts, and specifically about citrate being readily absorbed, but carbonate having to be taken with food. And I guess related to that is the question of how good is Tums as a calcium supplement?
Yeah, so Tums is available and cheap. It's calcium carbonate. There's, chewable Tums that do not taste very bad. They don't taste bad. People take them all the time for indigestion. So, and they're perfectly fine for calcium supplementation. As you alluded to, Mel, it really depends on the conditions of intake. So, for example, we have patients with inflammatory bowel disease who are on acid blockers like proton pump inhibitors. Calcium carbonate may not be the preferred salt because it has low bioavailability under those conditions. So it depends a little bit on the specific clinical situation, but I routinely recommend calcium carbonate as my go-to because it's cheap and widely available.
And just out of curiosity, in a patient who is at risk for peptic or acid-related disease, do you worry about the rebound effect on acid stimulation that calcium can produce several hours later?
Yeah, that is correct.
Is there, I mean, you just leave them on again, do you leave them on a blocker, but then you may interfere with calcium?
Yeah, I think if you take it with food, it's okay. Yeah, clinically speaking, I haven't seen that. It might be more of a physiological readout than a clinical thing.
And there's a question here about the use of bone density in measuring or assessing for fracture risk, especially in non-weight bearing children's, and how you interpret vitamin D and calcium supplementation in those kids.
Yeah, so I mean, DEXA really is not the preferred method for axial skeletal fractures as a way to screen for those. I mean, you do get an X-ray image of the skeleton, but I don't think it's sensitive enough to look for small fractures. There is an emerging role for vertebral fracture assessment using DEXA instead of conventional X-rays. That includes in children, because the technology has advanced to a point that the X-ray studies are really good and they're done with low radiation. So, I mean, on that aspect, if you suspect a vertebral fracture, that might be a way to go. There is caveats concerning maturation of the skeleton, because in an immature skeleton, it's less mineralized, and therefore you may not get the same sensitivity as in older kids. But generally speaking, it is emerging as a tool. In the kid that I presented, we did a modified skeletal survey because, like we would do for a kid with non-accidental trauma. And the reason being is because the kid really was crying in pain, and we thought that kid had multiple fractures. By the way, what I teach my residents to do the following experiment. So I tell them, put 2 eggs and hard boil them. One of them, however, just crack a little bit. So the shell integrity is a little compromised. And you'll see that the egg that was cracked swells in comparison to the egg that doesn't. So, and that's basically what happens in an unmineralized bone. It swells. So when it swells, it's pushing on the periosteum, and that causes the pain. So imagine yourself having a toothache of your whole body, right? That basically is what happens with these kids. And to me, and I cannot explain it, but when you get vitamin D, like in a day or two, the pain just goes away. So I think the bone starts remineralizing and the swelling basically goes down and the kids feel a lot better. So
related to that, well, 2 things. One is, do you recommend DEXA scans on children who have chronic disease?
it depends on the disease and the specific conditions. So for example, in inflammatory bowel disease, we used to say scan everybody, but now we're much more kind of restrictive. And we scan kids who have chronic active disease, who are exposed to steroids, who exhibit growth failure, who are just difficult to treat. And so the scan is going to give us almost uniformly lack of adequate skeletal mineralization. And so what do we do with that information, right? So because we do a test to do something. So sometimes it helps us to present to the family that the kids need escalation in therapy, for example, or present the case for nutritional therapies in addition to anti-inflammatory therapies. So it's a tool in that regard. In most chronic children diseases that are not primary bone diseases, so not osteogenesis imperfecta, not McCune-Albright syndrome, not any of those things, but in kids with IBD, liver disease, celiac disease, etc., bones get stronger if you're able to address the primary disease. So if you can control the underlying illness, you can adequately nourish those kids, decrease inflammation, promote function and activity, the kid skeleton does respond. Very few of these kids need bone active therapies.
Thanks. There's a couple of questions here about vitamin D levels in children who are overweight or obese, and what are recommendations regarding vitamin D levels when the BMI is increased. Any thoughts on that?
Yeah, I mean, so it goes back a little bit to the debate about what's sufficient, insufficient, et cetera. So there's no really specific recommendations for overweight, obese individuals as far as that is concerned. So it's basically the same recommendation. However, it's very common, as everyone knows in the audience, that vitamin D levels, 25 OHD levels, are low in overweight, obese individuals. And with weight loss, those levels actually increase. So the prevailing hypothesis is that the vitamin D is there, but it's sequestered in the fat tissue. At least that's one of the hypotheses. So there's really nothing different in terms of a specific benchmark for overweight, obese individuals in vitamin D level.
So if they have a low level, do you supplement them?
Yeah, we do. We do. I mean, you know, you may, I'm sure you've seen this, Mel, that a number of our kids with IBD start malnourished and they become overweight as they get better. And we don't use much prednisone anymore, but, you know, they feel better and they eat a lot. So, you know, we have to supplement them.
This might be a tough one, but there's a question that just came up about vitamin D and calcium recommendations for children with HIV or on TDF where there are known side effects for bone demineralization.
So can you repeat the question again, Mel? What is, so the kids with the HIV who are antiviral therapy at risk for bone demineralization?
Correct.
Yeah. So I don't study that area well, so I can't really comment. So yeah, sorry about that.
Okay. Maybe I'll throw one last quickie out. I'm curious how we know that in the high latitudes that there's a lot of risk for vitamin D deficiency in humans. How do the animals adapt? You know, to the sun not rising more than 45 degrees?
Well, I think some animals actually do develop vitamin D deficiency, but unlike us, they typically don't wear clothes. So whatever vitamin D, whatever sun exposure they get. All
right. Well, I want to thank you, Francisco, for a wonderful talk and discussion. And before I turn it back over to Dr. Hirsch, I'll say go Giants.
Go Giants.
Well, thank you, Mel. I definitely concur with the last sentiment. And I want to thank Dr. Sylvester for a wonderful grand rounds and thank everybody in the audience who participated and asked their questions, and wish everybody a good rest of your day.
Thank you very much for the opportunity. I really enjoyed it.
Thank you.
Our
Have a good
pleasure.
day.